This video will help answer some of the common questions regarding managing a heparin infusion. We will briefly review the heparin protocol and identify some common errors and resolutions, as well as some epic tips. So, when do we use heparin drips? This is a snapshot of a heparin order set with different intensities, goal PTT, and indications. Here is a quick reference table from the heparin protocol. We use adjusted body weight for non-pregnant patients. This can be found on the order itself or in the expanded table when you hover over the sidebar navigation. Also, when you scan the Alaris pump, adjusted body weight will be automatically accounted for. Now, we are going to talk about boluses. The difference between initial bolus and PRN bolus is the timing and parameters we use. For the initial bolus, we use it before starting the drip based on weight. However, in certain situations, an initial bolus may not be required per MD order. PRN bolus is given when PTT remains low after starting the drip. Let's walk over how to calculate dose for boluses. First, enter PTT into the adjustment calculator to calculate the PRN bolus, as highlighted at the bottom right. Note that the maximum PRN bolus is 5,000 units, hence, it will cap at this value. Next, copy and paste this number into the administration detail dose as highlighted in the middle of the screen. It's essential always to double-check the dose and epic alerts. Now, let's talk about ordering labs. It is crucial to manually adjust PTT labs 6 hours from the start of the drips. Not from the start of the order, since labs are automatically attached to the order. We need baseline PTT before the drips is started and every 6 hours after starting to adjust the rate. Now, let's talk about some potential mistakes that we've seen in our hospital. That leads us to a potential mistake, one of delaying therapy to wait for the result of the baseline PTT. In this example, the heparin drip was ordered at 19:30. This heparin drip was started around 4 hours after the baseline PTT lab was drawn. To resolve this issue, we start infusion soon after baseline PTT is drawn to avoid delaying treatment. The delayed therapy will throw off the subsequent PTT schedule. The next potential mistake is starting the drip based on baseline PTT and not the specified rate as detailed in the order. This is what was done. What do you think is wrong here? The rate was adjusted to 22 based on the PTT of 33, not the starting rate, as highlighted in the green box. As stated in the initial dose calculator, we enter the dose of 18 units and ignore the adjustment calculator, as this is the initial start. To reiterate, we do not start infusion based on baseline PTT. Instead, follow the initial rate as detailed in the order and use the initial dose calculator when starting. The next potential mistake is not rescheduling PTT 6 hours after starting or titrating rate. Looking at this timeline of rate change and PTT lab drawn, what do you think went wrong here? The correct lab draw for PTT should be scheduled at 14:30, 6 hours from the rate change. In this mistake, it was drawn only 4 hours apart. To avoid this, the PTT lab order should be reviewed and double-checked at every rate change or after starting the drip. The last potential mistake is not following the complete protocol when responding to the critical aPTT. In this example, the initial rate was started at 1600, starting with 18 units. Take a look at the PTT timeline and the instructions attached to the order. What would you do? First, we stop the infusion for PTT greater than 150 at 21:59 and continue to hold and check PTT every 2 hours until PTT is less than 100. At 0247, PTT is 95, which is okay to resume the drip, but with a decreased rate by 4 units of when the rate was stopped, which is now 14 units. Then continue to recheck PTT every 6 hours. Now at 0855, PTT is subtherapeutic at 46. We would give a bolus of 30 units per kg and increase the rate by 2 units to 16 units. Tips to approach critical PTT are to follow the protocol closely and check when PTT is supertherapeutic. Here is a quick snapshot of the guide to managing critical PTT. Now, let's recap what we discussed in this video. Bolus and when, or how to bolus. Epic alerts need extra attention, as well as how to use the correct dose for boluses. Lastly, the timing of the PTT draw and correct rate adjustments as detailed in the order are extremely crucial. These are some considerations to keep in mind when managing a heparin infusion. Thank you for following along. Please reach out if you have any questions and continue to save more lives and improve our patient care as you have always done.